It's Dr. Suchard again with another entry in this video discussion series on clinical toxicology. This time we're talking about cannabinoids, corresponding to Goldfrank's chapter 74. Not too many objectives this time, since this presentation is a lot more descriptive than chock full of high-yield nuggets. But you should definitely be able to name the primary psychoactive compound found in marijuana and marijuana-derived products, and be able to name/identify the receptor that it interacts with. While caffeine and ethanol are the psychoactive drugs most commonly used and with the highest number of exposures, marijuana has the distinction of being the most commonly used illicit xenobiotic in the United States. I don't think this should surprise anybody. The primary psychoactive compound found in marijuana is delta-9 tetrahydrocannabinol, or THC. I think it's interesting that, if you track the THC content of marijuana over the last few decades, the growers have been able to breed and select for strains that contain increasing amounts of THC, so arguably they are making a better and better product. If people are intentionally exposing themselves to THC, there must be a mechanism of how it works. THC is one of many substances that interact with cannabinoid receptors, or CB receptors, in the body. Both CB1 and CB2 receptors have been identified, but it's the CB1 receptors that are involved in the psychogenic effects of cannabis. So, marijuana is the plant product containing THC, making THC a phytocannabinoid. Marijuana is an exogenous source of cannabinoids, but if it acts on a receptor in our bodies, there ought to be an endogenous substance that binds to that receptor. Anandamide here is an example of an endocannabinoid. There are also a number of synthetic non-plant-derived compounds that are cannabinoid receptor agonists, and there are even some pharmaceutical agents developed that are CB1 receptor antagonists, such as rimonabant. The way the CB1 receptor works is unusual. For most neurotransmitter systems, the neurotransmitter is stored in vesicles in the presynaptic neuron, and it gets released into the synapse and then binds to a receptor on the postsynaptic neuron. For endogenous CB1 signaling, there will be a release of a different neurotransmitter from the presynaptic neuron, which induces endocannabinoid synthesis in the postsynaptic neuron. It gets released from the postsynaptic neuron and traverses the synapse backwards to our normal way of thinking to bind to CB1 receptors on the presynaptic neuron. This results in effects that hyperpolarize the presynaptic neuron, making it less likely to release more non-cannabinoid neurotransmitters, and thus creating a negative feedback loop. And then finally, the endocannabinoid signal is turned off when it is uptaken by facilitated diffusion back into the postsynaptic neuron and is metabolized away. Harkening back just a couple of slides, we mentioned that there are a number of synthetic cannabinoids that have been developed. And if we compare their structures to THC, we see that a few of them very closely resemble THC, while a lot of the others have pretty dissimilar structures. And speaking of synthetic cannabinoids, this raises the issue of the increasing number of different ways people can become exposed or intentionally expose themselves to cannabinoids. It used to be that marijuana, or hashish, a marijuana-derived product, were the only ways. A fairly recent trend was the development of K2 and spice, which were smokable, non-cannabis organic plant material to which they added some synthetic cannabinoid. Until the time that these synthetic cannabinoids were made illegal, spice and K2 were being sold as legal alternatives to marijuana that would give the user the same kind of effects. And the fact that these products were smoked, in the same way that one would smoke marijuana, made them more customer-friendly and familiar. And you've probably heard of marijuana edibles. THC can be added to, well, just about anything, and it can be eaten rather than smoked. For palatability reasons, and for marketing reasons, many of these edibles are sold as candies, gummies, cookies, or other snack foods, leading to some pretty appealing and impressive packaging. So the potential danger to children who now see something that looks like candy should be obvious. Heck, there are plenty of cases of adults getting accidentally intoxicated by these products when they were mistaken for normal foods. We already saw that the THC content of cannabis plants is going up, but some users might prefer products with even higher concentrations of THC to ingest or to smoke, and there are several such cannabis concentrate products available. With regard to clinical manifestations seen with cannabinoid exposures, the desired effects are psychologic, with some perceptual alteration, feelings of well-being and giddiness. Getting the munchies or an increased appetite is commonly recognized, even if that might be considered more of a side effect than a typically desired effect. And people can occasionally experience dysphoria, and particularly common here is the kind of paranoid ideation that everyone else around you must know that you're high. Cannabinoids do make your eyes red. The technical medical term here is conjunctival injection. And another ocular effect is to reduce intraocular pressure, which is why cannabinoids can be used to treat glaucoma, a condition where the intraocular pressure is too high. Acute cannabinoid toxicity may occur, but for people intentionally using these drugs and not in ridiculous doses, they're probably not going to be seeking or needing any kind of medical care. With unintentional exposures, say as with a child who thought they were eating gummy bears but they were marijuana edibles, or someone who really liked the edibles and ate too many, those are scenarios where seeking medical care is more likely. In most cases, you just see an exaggeration of the expected CNS effects. There have been cases, especially with the synthetic cannabinoids, where patients present with severe toxicity, and in the worst cases, most often closely resembling a severe sympathomimetic toxidrome, with agitation, seizures, tachycardia, and also some cases at the other end of the spectrum with somnolence and bradycardia. However, for all of these instances, the care needed is symptomatic and supportive. There's a marijuana and cannabinoid-related problem receiving a lot of attention recently called cannabinoid hyperemesis syndrome. This is more commonly seen among younger patients with histories of chronic heavy cannabinoid use. They will develop recurrent episodes of gastrointestinal complaints with nausea, loss of appetite, sometimes even resulting in weight loss, and they can develop more severe symptoms with abdominal pain, prompting them to seek emergency medical care. We see these patients quite frequently in the emergency department. They can look and feel very sick, and when you do a clinical workup with lab tests and radiographic imaging like CT or ultrasound scans, you typically don't find anything seriously wrong. If you find anything, it's usually that they're dehydrated or have some electrolyte disorder from vomiting that anybody vomiting that much might have. The nausea, vomiting, and abdominal pain can be hard to treat, with patients often requiring multiple rounds of medications. Some clinicians have been relying more heavily on dopamine-blocking antipsychotic medications to help control the nausea and vomiting. And there's another very notable feature of cannabinoid hyperemesis syndrome. Patients often find out for themselves through trial and error that taking a hot shower or bath will help to relieve their pain, and they might compulsively bathe a lot more often to help control their symptoms. It's also been found that topical capsaicin, the active ingredient in hot peppers and in pepper spray, can similarly help. And it's believed that both the hot water and the hot peppers trigger the TRPV1 receptor, one of the body's heat sensors, and that some altered TRPV1 signaling may be part of what's going wrong in cannabinoid hyperemesis. And the last thing I've got to mention about marijuana and THC relates to urine drug testing. For most drugs of abuse, your urine will test positive for that drug for a few days afterwards. And the same is true for occasional use of marijuana. But people who chronically use marijuana, but were to stop, say because they have a work-related drug screening test coming up, their urine can test positive for a month or maybe even longer. That's just a little hint in case this ever happens to be relevant for you. Don't use drugs, kids, but if you do, know when to stop so you won't get caught. That's it for this video discussion on cannabinoids. I'll be seeing you around.